Hello, this is Dr. Husain, and this is a presentation around questions around Lyme borreliosis, Lyme disease, and the challenge of diagnosis. So this is going to be a little different to what you may be used to. Now, Socrates has said learning is not filling a vessel but sparking a flame, and the aim of this presentation isn't to load you with medical facts, but it's in the hope of sparking something in you. This is a complex infection, and hopefully this will spark some further learning. So this is a spirochetal family tree. Over here you find syphilis, and over here you find Borrelia. And here you will find the different branches of Borrelia that contribute towards the clinical picture of Lyme disease or Lyme borreliosis. So you have Burgdorferi over here, and more commonly within the UK and Europe, you'll find Apsali and Guarini as causes of infection. And one of the common questions is, well, why is there such a variety of presentations? And when you look into infections, you find actually this is fairly common. So disease depends on the local environment, depends on the infection itself, how virulent it is, which branch of the infection the patient has picked up, and also on host factors such as their genetics, their immune system, their nutritional state at the time of becoming unwell, how run down or tired they were. And as an example, with polio, most people equate it with paralysis, but in fact, about 90 to 95% of people who pick up the polio infection either are asymptomatic or develop mild symptoms such as sore throat, fever, muscle aches, gastroenteritis, and 5 to 10% have the neurological symptoms from and then an even smaller proportion have, for example, paralysis. Some of those recover and some of those are left with long-standing disease. And TB is a similar situation where the majority who contract TB, their immune system deals with it and they're fine, but a small proportion end up with severe disseminated disease, and those are the ones that we encounter as doctors. And to the statement where this seems to be a recent thing, I've never heard of this before, if you look into the literature, Lyme disease has a very, very long history. And briefly, from the 19th to 20th century literature based in Europe, they discuss the clinical entity affecting the skin and neurological manifestations. It later became apparent it was associated with tick bites, and then in the 20s and 30s, whether it's infective or whether it is a result of a toxin from the tick. And then in the 50s, it became clear it was an infectious agent, but it was unclear what the infectious agent was. But there was improvement with the use of antibiotics. The early US literature, there's a description of the disease in European migrants, and then it seemed to have been forgotten in the later decades until the 1970s, where there was an outbreak of pediatric clinical Lyme disease comes. It just so happened there was a European fellow working there who recognised the rash that some of these patients had, and so the connection was made with the disease present in Europe. And then with more research and some really interesting epidemiological work, they were eventually able to isolate the spirochetes, Borrelia, behind this. And then with regard to transmission, there's no proven minimum time for transmission of the infection from an infected tick bite. And then the other factor is that ticks are tiny. It's very difficult to notice them, and they also release a little bit of local anaesthetic when they bite. So there are many reasons why a patient may not be aware they were ever bitten by a tick. And the other thing to be aware of that ticks don't just carry Borrelia, they can carry a multitude of infections. They are dirty. And then so you may be thinking to yourself, well, one, should I be thinking about Lyme disease? So oftentimes it'll be a patient who's normally completely fit, well and active. You normally never see them, and then suddenly they're really rather ill, and it's not clear what's going on, and they're not getting better, and there's lots of things going on in lots of systems. They may have a history of spending time outdoors, usually through the spring and autumn, but not always. They may have the rash, and if they do, you've got your diagnosis. And they may continue to deteriorate and developing these new odd symptoms, and this can occur over days, weeks, and months. And there comes a point where you realize, well, watchful waiting, it's served its purpose, it's not appropriate anymore. We need to do some figuring out. And then broadly, it presents with three different stages. In the first month of infection, it can all be very non-specific. Third, patients have an erythema migrans rash, that's local. Could be just under the weather, they are tired, they may have fever, they may be off their food, they may be beginning to lose weight, headaches, sore throat, there might be a bit of lymphadenopathy, but it's all quite non-specific. Then beyond the first month, that's when you begin to see signs of early disseminated disease, where it might be affecting certain organs. There's a tropism for it's affecting the skin, heart, joint, eyes, the nervous system, but it can go anywhere. And there's histological evidence of it in multiple different organs, including the liver and spleen. And at this point, this is where you'll see potentially disseminated erythema migrans, which will be distant to the original bite. And sometimes it may only be visible after they've had a shower. So they become nice and hot in the shower. There's multiple disseminated lesions visible, the skin cools down, it disappears, they have another hot shower, the rash appears in exactly the same sites. And the third stage is late disseminated disease, and that can occur years after the infection. In the educational literature, there's a lot of discussion about a bullseye rash, and that's usually only present about 20 to 30% of the time within the erythema migrans rashes. More commonly, it's a uniform rash, but it can have other appearances. And this set of photographs is from a paper that came from the original 1970s, 1980s cohort in Old Lyme, and you can see here examples of disseminated disease, but also quite a uniform appearance. And with these rashes, they may be hot to touch, they might be completely asymptomatic, they may have a burning or itching or painful sensation. Now, a lot of the photographs in the educational literature show rashes in skin that's of a northern European skin tone. Now, the thing is, with ticks, they are equal opportunity beings. They will bite whoever comes their way. But unfortunately, the variety of skin tones that are impacted are not representative in the educational literature. So we've included some examples here of erythema migrans in darker skin tones. And then the other difficulty is that consumer cameras are not calibrated for diagnostic color accuracy. So what that means in real terms is that the redness, the erythema, the pinkness can be toned down, sometimes to the point where it disappears entirely in the photograph. And in the age of telemedicine, a relevant question to ask patients, if you've got a photograph and you can't see any redness, is you ask them, is there a rash, a redness, a pinkness that I can't see in the photograph but you can see with the naked eye? And it's important to remember this affects non-white skin tones more than white skin tones. Now, another presentation in the skin is this borrelial lymphocytoma. Now, this is quite a dramatic example. Usually it's more subtle than that. And it's not just in the earlobe. It can be a swelling that's in the lips, in the nipples, in the genitalia. And then a later sign is this, acrodermatitis chronica atrophica, and it's more common in European disease. Now, I'm going to give you a brief run through of some examples of disseminated disease. So when it affects the nervous system, it's known as neuroborreliosis, and you may see facial palsies, encephalitis, other cranial nerve deficits, meningitis, radiculitis. There may be a loss of balance or proprioception, but it also may mimic other conditions such as Guillain-Barré or neuropsychiatric illness or motor neuron disease. And then when it affects the joints and vessels, it may be transient or migratory arthritis or pains in the muscles and tendons, and vasculitis has a multitude of presentations. And then briefly on Lyme carditis, this is where you've got an example of why it's known as the new great imitator, and that it presents in so many different ways. But there can be a variety of presentations, from arrhythmias to pericarditis, myocarditis, or a combination picture. There's reports of heart failure, and reports of deaths, and often it's a posthumous diagnosis and found on a autopsy. There's a lot of debate in the literature regarding prevalence, but it's generally put somewhere between 1 to 16%. And again, there's arguments and debates within the literature about, well, is it actually rare, or is it underreported, or could this be an unrecognized cause of sudden death? Is it just undocumented? And then you listen to all this, and I imagine you're probably thinking to yourself, well, how am I expected to figure this out? And this is where I put to you our training comes into play. And it's about getting the basics right. There's a difference between a person who memorizes their times tables and is able to recite them, and then a person who has the skill set to be able to take any equation and work it out from first principles. And it's a similar sort of a situation where majority of our workload is pattern recognition. But sometimes there are moments where we have to stop and think, okay, well, actually, this isn't fitting a particular pattern. We need to work this out. We need to go back to first principles. You will have heard through your training, you won't make a diagnosis of which you aren't aware. And this is where it's important to have a set of differentials to think and consider. And rare isn't rare. There was an interesting talk I attended a few years back on the Genome Project, of which has two branches. One is on cancer, and then the other is on rare illnesses. And while on an individual level, yes, rare illnesses are rare, when taken collectively as a group, they're actually more common than the common illnesses. And for many of these patients, it can take 7 years until they get a diagnosis. And I've put a quote here from Carl Sagan, where science is a way of thinking more than it is a body of knowledge. So there are times when we need to bring out our inner Sherlock Holmes when the occasion arises. And diagnosis matters. Diagnosis makes a huge difference in the outcomes of the patient. When a patient receives a diagnosis, they're en route to getting appropriate treatment, of getting the necessary support while they're ill, be it financial or other support or insurance, but they get a chance at treatment and a chance at recovery. Now, when a patient doesn't receive a diagnosis, they're kind of caught in this no man's land, this medical wilderness. And there's quite an interesting definition of no man's land, where it's a land that's unoccupied or under dispute between parties who leave it unoccupied due to fear or uncertainty. And that's quite a good description of what can sometimes happen to patients. And without a diagnosis, you can't really treat, and you then run the risk of the patient having preventable deterioration, morbidity, and potentially mortality. Now, as GPs, we do have certain advantages. We know our patients, we know our patch, and sometimes disease can be local. There'll be patterns that might appear locally before they become apparent in the official numbers. We generally have a common sense and pragmatic approach, and we're quite good at handling uncertainty and the concept of the working diagnosis, or making decisions based on what's in front of us, but willing to change that working diagnosis, to hold it lightly when new information comes to our awareness, so we can adapt things and change things and do things better for the patient. Now, here we will have a little thought experiment. This is a picture of the South Downs. It's a very beautiful part of southern England. Now, we're going to imagine we're in a game show, and you're told you're going to be given a map of the South Downs, and you think to yourself, I know the South Downs, I walk it frequently, this will be fine. And you're told you need to get from position A to position B as quickly as possible. So they blindfold you, they put you in a helicopter, you're dropped off at a site, you remove your blindfold, and you're looking directly at the map. You are utterly focused, you're looking at the markers, you're looking at the landscape, you're not finding the markers, you're looking back at the map, you're looking back at the landscape, it's hitting you that this isn't making sense. And then you're beginning to notice actually the weather's really rather hot and the sun's rather intense and you're having trouble walking due to the sand. And then you hear this unfamiliar sound coming from a four-legged creature and you take a closer look and you realise it's not a sheep and this isn't the South Downs and you don't know where you are, but you know this map isn't going to help you. And sometimes in the consultation room, it can feel a little like that, where you're looking at the guidelines, you've got your knowledge, but what's unfolding in front of you just doesn't seem to match. And this is where it's important to go back to our first principles, our navigational skills, skills that we have. And with regard to evidence-based medicine and randomized controlled trials, they are so important. They've helped progress medicine in so many ways, but they're not infallible. Sometimes it's information that's beyond the paper that we're critically appraising that needs to be appraised to uncover the underlying problems and weaknesses. So I have three examples here. One is Tuskegee. For those who aren't aware, it's quite a toxic part of medical history. So back in the 1920s, there was a group who did a retrospective study of medical records to uncover the pattern of syphilis over many years. And they published this, and then the people in the study group in Tuskegee saw it and thought, wait, hold on, why don't we do a prospective study? But the trouble is, by that point, there was treatment. It wasn't antibiotics, but it still worked reasonably. So they got around this by offering the guise of free medical treatment to a population who were poor, largely illiterate, and who weren't able to access the local public health messaging of the time. So they would pick up people who had developed syphilis and watch them over many years as they progressed. And this happened over the course of 4 decades, and it only came to an end in the 1970s when somebody whistle blew. And then we've got the example of Purdue Pharma and their contribution towards the opioid epidemic, not just in their approach to marketing, but also the way they withheld certain information in their published studies. And there's some really nice investigative journalism that uncovers a lot of this. And then with regard to bisphosphonates and research fraud, there's a really good piece of forensic statistics that uncovered that the initial studies on bisphosphonates were fraudulent. But the current problem is that the data from those studies is used in meta-analyses, the conclusions are in guidelines, and it's very difficult to take out that fraudulent data once it's out there in the literature. So it's... And then we come to observation and how much it matters. So we all know about antibiotics and how if we wouldn't necessarily have had antibiotics at the time it was discovered if it wasn't for the fact that Alexander Fleming was quite observant, and when he returned to his less than meticulous lab after a holiday, he made observations and then followed them through to then lead to the discovery of antibiotics. And then when we look at eponymous conditions and the history behind how they were found, a lot of them are based on very detailed observations on very few patients. So Parkinson's, an example, was based on 6 cases, and then Wernicke's was based on 3, including the pathology after they passed away. And all of these were then followed through later in time by other researchers who asked the question, can I confirm these observations? Can I build on them? So science and medicine has been built on a sense of humility and progress. So in the next slide, we have an exercise. So I'd like you to interpret this picture. All right, so this is where I've paused. Arlene, can you hear me? So when this was shown in previous presentations,
Zahra, you're still recording.
I've stopped it because I tried to use a keyboard shortcut. Can you hear me?
Yes.
Yeah. So this is where I'd like to see in the chat people suggesting what they think is going on in this picture. At the moment, I see silence in the chat.
So if you can put your answer to Zahra Husain in the chat, then Zahra will see your answers there.
All right, so far we have nothing. So somebody's written down a bar scene, a man sleeping. Any more? A man sleeping in a chair, man taking a nap. Any more for any more?
Someone texted me, relaxing with his hands swollen as he has been bitten by a tick.
Oh, okay. Oh dear, that's a good one. So there's one, man and grapes everywhere, mold, smoke inhalation, bloodletting. Okay, some good suggestions there, ones that I haven't seen before. So I'm going to play and we'll go from here. Sleeping man, he's passed out after drinking. Could this be a murder scene? But in fact, the reveal. It's a very different picture. It's a portrait of a man in the 1800s, an exhausted father after spending the night caring for his sick child. You can see he didn't even have a chance to get changed after he returned from work. His coat upon his child, the candle that's been kind of lit all night, the morning light coming through. He's fed his child, there's a picture book to entertain, and the child has survived the night. Now, the idea behind this exercise was to show that sometimes that initial impression may not be correct, and that as more information comes to light, it then becomes clearer what's actually going on. And for us to have that thought at the back of our minds, is there something that I'm not seeing? Is there something that either I've not noticed, or the patient has not noticed, or has been disregarded, or is there something that will become uncovered as time progresses? Now on to Lyme Carditis again, and to go a little deeper. So there are a number of post-mortem case studies. Some of them where there was an existing suspicion when they were alive, but for some of them it was organ donors. And you know, one of the organ donor studies, the pathologist based in Atlanta who saw these cases noticed that yes, it was myocarditis, but it wasn't entirely typical for a viral myocarditis picture. And he'd worked in New York, he had some experience in the Lyme endemic area, so he had the thought, hold on, could this be Lyme carditis? So he went on to do the specific staining, the specific test, and uncovered a case that was thought to be sudden death due to a viral myocarditis was in fact a Lyme carditis. And then with that they identified 2 further cases. If it had been a different pathologist who hadn't had that experience, you know, could those 3 cases have been lost and not identified? Now, this is Joseph Valone, who was a 17-year-old young man who was a promising student. He was planning to go to Brown University. He spent 2 weeks working on an environmental project. On his return home, he started to become unwell with a flu-like illness during the summer. So his parents took him to the doctor, who said it's probably flu. He then continued to deteriorate. He went back the following week. Again, probably flu, but they ran some investigations, including for Lyme disease. And in the week after that, he collapsed in his mother's front garden. He was taken to hospital, transferred to another unit when he was found to have arrhythmias, and then he died the next day. Now, when they did the autopsy, they found he had disseminated Lyme disease, his heart and other organs affected. When the test came back, it was negative. And what this highlights, and he didn't have a rash while he was unwell. So this highlights 2 things. One, that a person can have disseminated disease, not have a rash, and test negative, and they can die from Lyme disease. The other thing to bear in mind is that he also had Powassan virus, which was also picked up from the tick bite. So again, that there can be more than one infection coming from a tick. Now, this is Dr. Neil Spector, who was a oncologist at Duke University in the States. Unfortunately, he died last year, but he's written very eloquently about his experience of having Lyme disease, developing Lyme carditis, and ultimately developing heart failure, requiring a heart transplant. And as an oncologist, he expressed some frustration that the rigor that he was used to in the oncology research was lacking in some of the. Now, moving on specifically to a different idea. So when a patient has Lyme carditis or room and say to you, "Ah, yes, this is a presents undifferentiated." So let's look at the European Society of Cardiology Pericarditis guidelines. And here they have a very neat table. Under the bacterial section, you've got Borrelia burgdorferi. Now, when we look at the literature that's available to working clinicians, the presentations isn't alluded to. It's presented that it's generally viral, sometimes autoimmune, some very rarely TB, but generally it'll sort out in a week or two if you give them colchicine. But there's no information about what to do when it doesn't work out, when it doesn't get better after the first week or two, which makes it very difficult when you've got a patient who's continuing to deteriorate. And going back to the European Society of Cardiology guidelines, they acknowledge that pericarditis is a relatively common presentation, but there's a lack of epidemiological data, particularly in the primary care setting. So a lot of the data is based on hospital admissions. But it also acknowledges that the causes of pericarditis are varied, and it depends on the epidemiological background, the local patient population, the clinical setting. But none of that comes through in those summaries of guidelines that we have to hand. And this is just to highlight that actually quite relevant information is sometimes lost in summarization, all for the sake of brevity. And sometimes that can mean that some of these summaries can read a little dogmatic as a result, lacking the caveats and uncertainties that would otherwise be present in the other literature. And then I was looking further into the suggestion for use of colchicine, and in the guidelines, that suggestion is based on 4 studies, all in northern Italy and all led by one man, Professor Amasio. Now, he's done some brilliant work where, quite frankly, it's lacking. But with what he's written, there are very clear caveats in that if the pericarditic symptoms do not settle within 3 to 7 days of colchicine use, then the cause isn't viral, and that the cause needs to be actively sought, so bacterial or otherwise. And he has quite a useful list of major and minor factors for poor prognosis. But none of this is mentioned in the summary of the guidelines that we tend to have. And not everyone, not even the specialists, are going to head back to the European Society of Cardiology pericarditis guidelines when you've got a patient who's 4 weeks in and not getting better. Sometimes they may even persist with using the colchicine in that time. And what this can mean in reality, there's a risk that potentially treatable causes are being left uninvestigated, the patient's left to deteriorate, and it's really, really important to remember that pericarditis is not a cause. It's a presentation that needs the cause found if it's not resolving within a week. And then the other thing that's mentioned in those guidelines is that steroids can be an independent risk factor for recurrent disease, and it should be avoided if an infection or if infection is suspected. And it can leave people with, they might have instantaneous resolution of symptoms in the short term, but you run the risk of leaving them with lifelong disabling recurrent pericarditis alongside the side effects that comes from requiring regular steroid use. So things to think about. There's Dr. Neil Spector wrote Gone in a Heartbeat, which is very sentimentally written about his experience of having Lyme disease, Lyme carditis, and his journey. My Stroke of Insights is not about Lyme disease. It's written by a neuroanatomist who had a stroke in her 30s. And it's actually quite a good description of her journey through rehab and recovery, and lots of transferable lessons there, whatever the illness. Dope Sick, written by Beth Macy, is a really nice piece of investigative journalism behind the opioid epidemic, and actually there are lessons that are transferable there too. So I'd encourage you to have a read of those. Now, even if you've got an infection, you've treated it, there are still consequences of illness. The patient may well have lost a lot of weight. When they get to the point where they've lost 5% of their body weight, they're at risk of protein malnutrition. By the time they've lost 20% of their body weight, it's severe protein malnutrition and it needs addressing. Nutritional deficiencies can be very difficult to pick up. There are clinical signs that will guide you, but the testing isn't great. So, for example, vitamin C, there aren't great tests for it. But, for example, if they have the corkscrew hairs on their legs, you've got the diagnosis. And again, things that need treating. Thiamine deficiency, a patient may never have drunk a drop of alcohol in their life, but because of illness they will have developed it with cognitive difficulties and a wide-based gait. If you don't have the suspicion, you're not going to pick it up. And there are some really nice image libraries and tutorials, for example from Medscape and other places, to look into and have an awareness, because clinical signs matter here. And just as a general note, with bacterial infection it's best to avoid iron supplementation, because through complex mechanisms, iron can drive an infective process, and sometimes with chronic infections the body causes an iron deficiency anemia as a protective mechanism. And with long illness, there's the risk of atraumatic brain injury, and recovery from that takes a long time. The patient may have issues with balance or proprioception, and as they recover, there may be widespread tendinopathies. In the recovery phase, it's long. There's a Persian proverb, illness comes mountain by mountain but leaves you hair by hair, and it's quite a good description of how long it can take. There are some really good NASA studies where they've taken healthy volunteers, left them bedridden for periods of time, and then learnt how long it takes for them to recover, and generally it's 2 to 3 times as long as they were bedridden. And these are healthy volunteers who haven't had a catabolic process attacking their body. So you can imagine with illness, recovery is going to be very long indeed, and it's important for us to have realistic targets for patients and giving them targets that their bodies are capable of matching, and that recovery is organic. It's not a linear process. You know, you can support it but you can't control it, and pacing is an important part of recovery. You'll have these motivated patients, and sometimes you have to tell them, you know, you need to scale it back. You need to think about what you realistically can do and stop at 50%, allowing that other 50% for recovery. Don't underestimate the difficulties that come with healthcare bureaucracy, stigma, clinical error, and the ongoing need for problem solving. Sometimes problem solving hasn't happened even though the patient has seen multiple different doctors, so it's important to look at things with fresh eyes, and also the power and possibilities of physical rehab at the right time, and if they're not recovering as you expect, to use that as a prompt to look further. So in conclusion, history really matters. Clinical examination is important, and there are ways to do this via telemedicine. Know the rash, but no, it doesn't rule out the presence of disease. Infection has a multitude of presentations. Have an awareness of what's not immediately obvious or visible, and that the picture can change. If the map doesn't match with the ground, you need to look at things a bit further. Hold your working diagnosis lightly, and the evidential floor we walk on is not quite as sturdy as we may like to think. So here are some resources for patients, some for doctors, and many references. So thank you very much for listening.